From the Toronto Star, I'm Adrian Chung, and this matters. This year feels like a decade, but as we get to the end of a terrible 2020, it's worth stepping back for a moment to think about how far we've come. In March, the full scope of the pandemic hadn't sunk in yet. We didn't understand how it spread. We didn't know the best ways to protect ourselves. We didn't know if a vaccine was possible. Considering the abyss we were staring at in the spring, there's been a lot of good news. But we cannot underestimate the toll it's taken. The second wave is still rising, the number of new COVID infections far surpassing the first wave. More than 12,000 Canadians and 1.5 million others across the world have died. That's where we're at in this health crisis. Despair and hope, setbacks and advancement, fear and courage. So we're going back to where it started, back to the front lines of the fight. We're talking to Dr. David Carr, an emergency room doctor in Toronto with more than 20 years of experience. We spoke to Dr. Carr back in the first wave, then in the relative lull of summer, and now we're talking about what it's like on the ground floor of the second wave as we hope to see the end of the pandemic. Dr. Carr, thank you for joining us again.
Thanks for having me as always.
First off, working on the front line, we're almost 9 months on in this pandemic. How are you doing? How are your colleagues doing through all of this?
You're starting off with a big question. I think we're doing okay. It's kind of a question we get asked a lot. You know, we've been going through this for a long time, and I think people have to realize that physicians and healthcare workers are no different than regular people in terms of we're pretty burnt out with this and we're pretty fed up and frustrated. We all want our lives to go on too. We're human. So I think there's certainly that sense of, okay, are we almost done? That sort of mentality.
Yeah. Like even obviously working in healthcare, the stakes are heightened for you and the pressure remains high.
Yeah, look, there's a disproportionate amount of illness in healthcare workers. I think the difference as we've evolved since we chatted last is moving to this second wave. We certainly know a lot more about this disease. We certainly know a lot more and we're a lot more comfortable in our shoes. I think the first time round, we felt like we were guinea pigs in an experiment going in and hoping what we have works. And I think for the most part, what we have does work in terms of protecting us, in terms of our PPE. We have supplies, we have everything. Unfortunately, what hasn't happened is there hasn't been a dramatic change in the way we manage people. There has not been no panacea in terms of, okay, we have this new drug and now things are amazing. But we've had incremental gains and we're kind of celebrating those with other celebrations ahead.
You mentioned that, and actually before this interview, I looked back on my notes of the first time we spoke back in late March, and that was when COVID's first wave was really ramping up, and that is what struck me of how much we didn't know at the time. And of course, there are near record new cases and deaths every day here in Ontario and in Canada in the second wave. I'm not playing that down. But we have learned a lot in the last 9 months. As an ER doctor, what has been the most important thing that you've learned during this pandemic?
Yeah, we've learned a lot. To your point about cases and stuff, you have to put it in perspective. In Ontario, and where our latest numbers say, we have about 1,750 cases new of COVID-19 with 620 in the hospital and 168 of those are in an ICU. Now, when we look back at the first wave, some of these numbers are higher, but it's all a function of how we're testing. And I think we have to look at our hospitalizations and our ICU number, and we're not at the peak where we were at the first wave, but these are different times. Remember, what we have now is a society that's shut down locally in Toronto and Peel, but not in schools and not in hospitals. In the first waves, hospitals were shut down. Our kids were at home. Now we're trying to function. And I can't stress enough how important it is. To me, my goals are we want hospitals open and we want kids at school. The issue is, can we do this? Can we keep this as we keep limping towards, the late innings of this pandemic?
That there's a lot more gray area now, that it's not a decision between shut everything down or open everything up. There's been a lot of nuance in how we figure out how to live our lives through this.
Yeah, clearly what we learned, one of the main lessons was it can't be a province-wide shutdown. Economically, sociologically, that doesn't work. We also know the implications of shutdown and how troubling that is economically. And certainly there are learning lessons to be had provincially and federally in terms of how we will get individuals out of this situation. But if you're a person with COVID in rural Ontario, that's very different than if you're a person who is a citizen in urban Toronto or Peel or Brampton or Scarborough, some of the hardest hit areas in the province where positivity rates are super high. So we can't have the same restrictions for your downtown Toronto people as you do in Kapuskasing.
You mentioned burnout. I just wanted to go back for a second. You mentioned burnout for doctors and nurses and frontline workers. I know many people, even not in healthcare, are feeling burnt out. But what's been your best day of the last 9 months?
I'll tell you, my best day was the day when I heard the vaccine data. And I'll get to burnout, but that day I remember so quickly because, I'm checking the news in the morning and saw some of the early data for Pfizer and Moderna. And, my kids came down from getting ready from school. They had brushed their teeth, put their clothes on. And I said, guys, this is the best day because your life will be normal. Your life has a plan, and hopefully your summer activities, your hobbies, your sports will resume. There is a light at the end of the tunnel. And that was my best day when the vaccine data came out and blew us away. But I think we have to get there. And I think the key thing, which you mentioned, is burnout. And I don't think we can just brush that aside.
So how do you manage through that in the second wave, knowing that we are still months away from that being a widespread plan on a day-to-day level? As a doctor, again, how do we manage this thing through the second wave?
So let's just talk statistics. And I'll speak as a professional, as an emergency physician first. And regrettably, this is what I've chosen to do. Emergency physicians have the highest rate of burnout of any healthcare physicians. And what a study that was done, it's interesting. It was published in June in our national journal that looked at burnout in 2019. So this is pre-COVID stuff. And what they found is that in 2019, 86% of emergency physicians had felt burnt out, and 6% of them had contemplated suicide, which are alarming numbers. A similar group, a group out of McMaster, actually came out with a burnout survey to similar emergency physicians in the first wave. So they looked at the first 10 weeks of COVID, and what they found is burnout had not changed. And there was a lot of camaraderie in that first wave, pots and pans for healthcare workers. And we were like a family. We were kind of thrown into battle, and our comrades and our colleagues, we kind of bonded. But I can tell you, as they're working on the second wave burnout figures, I know this COVID fatigue has hit us. It's hit us hard, and I know the data will be worse because, look, I see it on my colleagues, and more importantly, I see it in patients every day.
I asked you in the first wave, and I imagine your answer to this question is different now, given the current situation, but what are you most worried about with the winter months ahead?
Look, the summer was a nice time. July and August, there were times where we were able to loosen things up a little bit. We know that this virus transmits in indoor congregate settings for prolonged durations. The summers was great. We had a really warm summer. We've had a really nice fall where our children and as adults, we've been able to walk outside, take the dogs out, kids have been able to play. I think the winter is going to be an isolated, lonely time. And I think that's going to be difficult to hold things down. I mean, the summer we could loosen up a bit. I think now the issue is what all these modeling and all these people thought about is they never took into account what fatigue does in society. When you do projections, you don't realize that you cannot continue to impose restrictions on people. At some point in time, they'll stop listening. They'll have fatigue. This is the whole Hawthorne effect. You throw things, people do it, but you can't keep doing it. The incremental gains are not there.
We'll be right back. We've also talked about this on the podcast, but in a number of provinces as well, there's been a lot of mixed messaging that provincial governments have been criticized for that, of where restrictions are actually happening, what the best practices are. And that too has shown that it leads to COVID fatigue.
Yeah, look, I mean, Canada's a huge country, and you almost have to look at individual provinces. The Maritimes have been the glowing lights of the country in terms of their ability to contain this virus for the most of the part. And I know one of my colleagues, he relocated to Prince Edward Island, and just telling me from going from St. Mike's in Toronto to PEI and hearing his life, I'm jealous. And we have to look right now in our prairie provinces, things are really rough and out of hand.
In the western part of our country, the situation with COVID-19 reaching a critical point. Alberta seeing a record high number of cases, pushing hospitals in the province to the brink.
You asked me about worry. Yes, I worried that things are heating up now as we get towards the twilight innings. But what really still worries me is two things. One, emergency department volumes have dipped again. So people in the summer were getting comfortable coming to the emerge, but as the prevalence of the disease has really picked up, people aren't showing up. So our volumes are about 70% of what they were. They're dipped. We're seeing a lot sicker patients, late presentations, COVID stuff, like we talked about in the first podcast. But the other thing we're now starting to see is the externalities and the indirect costs of COVID, which is the delay in care. There was an American study that came out that said, if you look at America and you just take breast cancer, which is a commonly studied condition, and if you delay breast surgery by 60 days, that will lead to 7% more deaths by 10 years. And that will mean 3,000 more Americans will have died from breast cancer as a result. You can extrapolate this data to many conditions. And that's the real hard part to think about is we want to deliver exemplary care. Do we have a system that's able to catch up with our backlog and deliver care when right now things are starting to fill up?
Right. And the illnesses that are coming in, they are at a more serious stage. Even if they are non-COVID, people are delaying their visits into the ER.
Big time. Like late presentations of heart attacks, late presentations of appendicitis. So normally you have a little bit of abdominal pain in your right lower quadrant, you get things checked out. Now you're afraid to come in. So you don't come in until it's perforated, you're septic, you're really sick, and that surgery needs to be done in an open fashion. You need to have drains put in. And there are many indirect costs that after the fact, when we take our lens, when we do that deeper dive, we will see the hidden costs of COVID.
When we spoke before, you had mentioned that it's important to note that Canada is not the United States. It's not parts of Europe. Granted, our record here has not been perfect. There have been thousands of deaths. The second wave is fully here. But you mentioned that we have dodged a lot of bullets. What are those bullets you think that Canada has avoided that other places perhaps haven't?
Yeah, look, I think when your neighbor has done so poorly, it's easy to shine. I think that as an emergency physician who's heavily engaged in social media, I look at a lot of my colleagues in Europe, in Italy, in Spain, in the UK, and the US, and I feel like an imposter because quite frankly, I have not seen the death and horror that they have. And not to trivialize what we see because it's terrible, but I can't imagine their reality. The reality of rationing oxygen, of rationing ICU beds, of making decisions of who gets a ventilator, of morgues filling up so that you're renting refrigerated milk tanks to keep dead bodies. I mean, that to me is terrifying. So we have done well, I think, comparatively to a lot of other nations, but you can look to Australia, to New Zealand, or to the Maritimes. You can look to the Asian countries, Thailand, Vietnam, Korea, China, and you can say, I'm jealous of them. So we're somewhere in the middle. My job as a physician is really not to be political. I think there are gains. I think you learn from your mistakes. The biggest mistake, I think, is, if I had to be critical, is I'm seeing the same wave of crippling long-term care again. I don't mean to be negative, but that's what I'm seeing now is September, October, we're really about 20s and 30s getting COVID. Now it's about 70s, 80s, and 90s dying from COVID.
Right. We are seeing again that many of the hospitalizations, many of the deaths are seniors in our population.
I mean, that's natural. This virus is gentle on children and is cruel on adults. So it's not surprising to see mortality and morbidity in that group. The issue is we just haven't developed a national strategy to test, to trace, to isolate. Healthcare workers in the NHS in the UK are now being tested with home kits that they're using rapid kits twice a week. Canada has bought a lot of rapid tests, but we're not using them. And I think to the person who says, hey, I'm in film or I'm in the NFL or I'm in the NBA or the NHL bubble, they're all using the kits. But your parents in long-term care and the healthcare workers looking after you, they ain't using rapid tests. We're just not using it where we need it.
I also wanted to talk about in the second wave that public health officials and doctors were warning about a twindemic, right? A bad flu season coupled with thousands of COVID cases. That so far, knock on wood, has not really panned out. Flu vaccinations are in high demand across Canada. Flu hospitalizations are also way down. Do you think that this is an example of best laid plans actually working out?
I think there's a lot of luck. I think the reality is what we know about most infectious diseases is they're prevented by good hand hygiene and washing and clearly masks. If we borrow the data from the Southern Hemisphere, and that's how we often track flu, is we look at how the Aussies and Kiwis did, and they did exceptionally. They had historically low influenza levels this year, and a lot of it had to do with physical distancing, hand washing, and mask wearing. So when you add that to vaccination strategies, people realizing the importance of vaccinations, because there's certainly a anti-vaccine movement. If you vaccinate and you protect, we're not going to get flu. And our numbers of flu are non-existent right now. Typically, flu starts a little bit later, but I think we're optimistic that flu is going to be really light this year. And I think, Adrian, people have to know, if you're in Ontario, during flu season, hospitals and ICUs are busting at the seam. We're over 100% capacity during those times. So we're kind of used to this stuff. If we can get rid of flu, hopefully we can kind of keep the brakes on COVID with lockdowns, with restrictions, so that we're able to keep hospitals running. Because I think, and fingers crossed, knock on wood, whatever you want to do, I really feel that if we do the basic public health maneuvers, I think flu is going to be light this year.
You talk about a panacea. It's almost like with the flu. Again, it's coupled with many things that many of us are distancing. We are wearing masks. Hand hygiene is up. Many people continue to work from home or following stay-at-home orders. So all of this, like it helps COVID, it also helps tamp down how the flu spreads, obviously, if there are people following good public health protocols.
It's so important. And, we look at certain cultures that wear masks and wash their hands and, we criticize them for being germophobic. I think the reality is it's been a slap in the face. Lots of people will say, if you stand outside a washroom at a Raptors game and you look at how many people have wet their hands, kind of gross. Now,
it's
I don't mean to
shocking.
bring
Yes.
that up, but the reality is, we have a long way to go. And hand washing is something that Austrian scientist named Semmelweis, who was really the father of really hygiene, really preached about being clean and how that would make a difference in operating rooms. And he was dead on. And now we're learning his lessons 250 years later.
I think some of the wording that you've used is interesting, especially when it comes to the vaccines. And I could see your face sort of light up when you think back to the news about the vaccines. Obviously, Moderna and Pfizer are both reporting vaccines with 94 to 95% efficacy. We are starting to see an end game emerge. We're not there, but we can see that light at the end of the tunnel. What should we be doing over the next 6 months to see this out with as little damage as possible, especially on a day-to-day ER level, you think?
So firstly, I think people have to realize that regardless of when we get our vaccines, Health Canada, the FDA have not approved these vaccines. This is happening mid-December. The average person isn't going to get the COVID shot till probably second or third quarter in 2021, if I had to guess. So we can't quit now. We really have to sustain and prevent transmission. I think we can't lose sight of the importance of, ramping up testing, which is nice to see provincially. We're now at, going up, testing more to really work on tracing and really the importance of isolation and how important that is, and make opportunities for people to isolate if they don't have the housing, the structure, the means to do it. So we can't let our foot off the pedal. We have to be mindful that the vaccine is coming, but 2021 is going to be a much better year than 2020, but we're not there yet.
Fingers crossed. Dr. Carr, thank you so much for taking the time to talk to us, and again, for all the work that you've been doing along with your colleagues.
Awesome. Anytime, Adrian. I hope the next time we chat, it's even more uplifting.
And that is Dr. David Carr, emergency room doctor here in Toronto. That's it for today. Thanks for listening. This Matters is hosted and produced by me, Adrian Chung, Saba Aitazaz, and Raju Muthar. Produced and mixed by Sean Pattinen, and our director of programming is JP Fozo. Our show theme music is by So Called, and our episode music is by Mike DeAngelis. We want to hear what stories matter to you. Please send us comments, questions, or ideas to thismatters@thestar.ca. Please consider supporting the journalism the Toronto Star newsroom does at thestar.com. And don't forget to subscribe to This Matters on Apple Podcasts, Spotify, or wherever you listen to your favorite podcasts. Let's talk soon.